Thank you, and I'm glad you managed to make it here, despite the chaos in London for the travel at the moment. So thank you so much for joining us tonight, and thanks the committee members who made the effort to come here this evening. So this meeting is going to be a hybrid meeting because of the issue I just highlighted. And this Adult Social Care and Health Select Committee, I am Councillor Marwan Al-Naji, the Select Committee Chair, and I will be chairing this meeting for tonight. As you know, this is a hybrid meeting, which means some officers are joining us remotely. This event is also being streamed live on YouTube, and members of the public and the media are welcome to watch the meeting remotely and listen to the discussion that's taking place. I would like to welcome all those in the room, officers and community members, and those who are watching online, and the officers joining us. As in all our meetings, I think it would be appropriate for us to start with a 72-second silence to remember those who lost their lives in the Grenfell Fire Tower tragedy. So I will ask Yasmin to start some of this time. Thank you. Thank you very much. Starting with this meeting, I believe all of you, they received the papers and the agenda for this meeting. During this meeting, if the councillor wishes to speak on any particular item that has not been called, please raise your hands and I will answer. So we start with the same format of the agenda, with the exception of item A3. I would like to move to the just before the work program. So item A1, apologies for absence. We received apologies for absence from Councillor Spalding and Councillor Ram. Any other apologies? No? Item A2, declaration of interest. I confirm that I have no declaration of interest to make regarding any of the items on this agenda. Do any members have an interest to declare? No. Proceed.
I am the Health Watch representative from the North West London Policy Committee.
Thank you.
I should add I am the Council's representative on the Council of Governors of CNWL.
Thank you. Now we move on to item 8.4, as it is stated on your agenda. We have a report from the lead member with an update on his priorities and key areas of adult care, social care, and public health. I would like to welcome Councillor Kamali and officers Natalia Clipper, Gareth Wall, and Biswa Sasasigan
Just couldn't be.
to this meeting to introduce the report. So welcome to the
Yeah.
Yes.
It's fully away from me.
I take the report to be read. It's a very extensive report. Thank you. We appreciate. So I assume you receive it and you make your notes and observation on it. However, I would welcome an overview, if you don't mind, within the 5 minutes, to guide us through the various key points, because I can see you have almost 8 points in the first one, then leaving for further extra 6 as additional priorities. So, any comment, Councillor Kamali?
Thank you, Chairman. I mean, really, what can I say? What a year it has been, not just for the council officers, for the council, but for all of our residents here in Kensington and Chelsea. It's been incredibly humbling to see the response from everybody, the way that they've handled the government guidance, the rules and regulations that we've had to live by for so many months and years. And they're just huge amounts of work above and beyond everything that these officers have historically had to do for the borough. This is something no one's really expected or predicted. And I just am really proud of the way that RBKC has handled it. We've challenged issues where we've found them, we've tackled problems, we've adjusted our response as necessary. We've appreciated the fact that we are a very unique borough, and that we've had to rise to that challenge. And I think that's something that we can all of us, including the committee, all the councillors, can take great pride in, and as should the officers themselves. I mean, obviously the paper sets out some of the priorities. Obviously, when these priorities were set, we were in a very different space. We were coming out of what was, I believe, the sort of the second wave, if we're going back to that one. We thought cases were going down. We were looking towards the future. How can we best pick up the pieces, especially around the mental health response, and also the sort of what we knew to be issues around physical activity. The number of people that have obviously spent so much time at home during the lockdowns, we knew that they had to be out again, getting their exercise. So just obviously some of the things which you'll have seen tonight is something that we've worked on throughout this, is actually embedding public health that much more within the council. They've obviously been very important over the last year, and we're often sometimes perhaps they've been telling us what to do. That what we've been able to work towards is making sure that the public health team is very much part of the council, in the same way that every other department and directorate would be. I think the paper that's sort of mentioned here really highlights the fact that public health has a really good role to play in solving so many of the challenges that we talk about so often. So inequalities in health, inequalities in access to physical activity, to all of the facilities within it. But also that sort of well-being element of it, and actually preventative measures that can stop mental health issues developing, and actually get there a little bit earlier. Before we have to rely on NHS services, we can rely on council services. Part of that is obviously you'll see that we've been able to reprioritize funding, and we mentioned it last night, that we'll be tackling youth violence. We'll also be looking at how we can help improve air quality as part of our climate emergency, but in partnership with public health, looking at the air quality element rather than the emissions, which is obviously more of a sort of environmental side of it. Some of the other things we've done, I mean, I've not mentioned the vaccination work that's been carried out across the council, led of course by the NHS. I think we offered them we worked in partnership with them when we addressed issues in vaccine uptake. We knew this borough has a long history of issues with vaccination, not least through childhood immunisations. But what we've learned so much through this whole process is that some of the issues we were seeing in childhood immunisation is exactly the same as we were seeing in the COVID vaccination rates. We've worked really hard to address our officers in particular. I know many of them even went into NHS surgeries and GP surgeries to try and help get our residents vaccinated. We've rung over 5,000 residents. We were the first borough in the country to go out and ring our residents working in partnership with the NHS. We've set first after first. We've campaigned for validation centres, knowing that we have so many international residents. The NHS put that on in the Science Museum. It started with 70 validations a day. I believe that went up to over 150, and now we have GP surgeries doing another over 100 as well. So we're around 250 residents who have been vaccinated and now able to be registered in their UK NHS number, so that they can travel around the country, the world, so much easier, as I'm sure COVID passes, and making sure people are vaccinated will be just part of life going forwards. It's sort of, COVID was so all-encompassing, it's often difficult to remember some of the other things that we've done, which is why it was so helpful to have it all presented and written in this report. I mean, the community champions themselves, they were out, they became vaccine champions, they became maternity champions, they're now also becoming well-being champions in partnership with the NHS. These are our residents, they're not just community champions, they're our residents. They're going out, making sure that their communities are getting the care that they need, being the eyes and the ears, that the council just can't be everywhere, nor should it be. It should be residents that are looking out for one another as well, and we just have to stand behind them with the NHS behind us. They've done a phenomenal amount of work, and I'm really sort of looking forward to the way that we can develop the model going forwards, really harnessing that enthusiasm for volunteering and community resilience. Part of that is how we're sort of tackling the health inequalities. That sort of leads on to the community health worker pilot. This is something that we'll be getting going in April. And that's really just working with the GPs so that we can go out to estates, some of the areas that have historically sort of higher issues of health inequalities, and just engage with them, find out what the issues might be, have those conversations that can result in people getting the care that they need, picking up problems before they become clinical, just making sure that they're getting, you know, everyday care that's so valid, so vital in their everyday life. The flip side of that is, of course, sport, physical exercise, and just the activities that we're going to be able to put on throughout the borough. Last summer, we did put on a sort of a day in Holland Park with lots of different activities for people to come and try. I know we've had with the Afghan evacuees in the borough, they've been playing cricket. We've got to offer the opportunity so that residents can find what works best for them. Not everybody wants to do yoga, not everybody wants to play five-a-side football, but we have to find out where that demand is. The recent Citizens Panel survey really threw up some answers I wasn't expecting. We saw Tai Chi being something that was so highly demanded, ping pong, for instance. So these are things that, you know, historically, I don't think we would ever have designed in a ping pong table into any of our activity centres, but now we will, because that's us listening to our residents. And even in that Citizens Panel, as it says today, the 42% that their physical activity decreased. This is a decrease during an obesity epidemic anyway. So we need to make sure that we get back not only to pre-pandemic levels, but improve upon that. We've also been busy recommissioning contracts and working to improve efficiency within the system, making sure that the contracts that we do have working right for the people that are using them. It's mentioned here in 2.6 around wraparound health service. This is something that sort of that prioritises support for those that need it, and offers those that don't need the support the opportunity not to have to engage so much, so that we can prioritise helping those that really need it that much more. What else have we done? Really, the list goes on, as the pages say. We've obviously had to also respond to government legislation. We've got the Health and Social Care White Paper working its way through Parliament. What the impact of that on the council is still fairly unknown. We've obviously put provision in the budget last night to make sure that we are able to react depending on the funding mechanisms that come through. We know in RBKC we're in a fairly unique position where so many residents do fund their own care, and I know this is a point that was raised again last night. I fully expect that once the government legislation works through, we will see more residents coming to the borough for their care. And obviously that's what the government policy is setting out to do. And we will have to adapt accordingly and build that resilience ourselves. I mean, it's really just been going on and on. Obviously, whilst through all of this, also the NHS itself has been going through an enormous restructure. We're looking forward to seeing exactly how that will shake itself out. But I can safely say that officers have been working through emergency response, business as usual, and also sort of a national picture that's been changing. And it's incredibly commendable to see that we've not only been able to fill this agenda this evening, but actually we've done all of these things. We are a year later, looking to the future, looking at how Kensington and Chelsea will be able to continue to care for its residents with all of these changes. And something I think we should also note and really pay tribute to is the work that was done not only on the dementia plan, which was so well received, but also on the autism strategy that involves over 200 residents in a pandemic reaching out and speaking to our officers and giving their feedback and their opinion on how best the strategy should be worded, how it should be written, and what they want to see it achieve. I proudly say I had minimal involvement in that document. It was our residents that wrote it and shaped it, and they have done a far better job than I ever could have done. So again, really proud of that, of our residents responding to that. It's very similar to the work on the dementia plan. I think, Mr. Chairman, that's a sort of a quick summary of what has been a very busy 12 months, but I'm obviously very happy to take questions as well. So thank you very much.
Thank you, Councillor Kamalis. Really good signposting on all these activities, which myself, I witnessed some in Holland Park, as you mentioned, the vaccination. And I use this opportunity to thank our NHS colleagues who worked tirelessly to respond to our need during this critical time. And I've seen the operation in North Kensington, the way it's been done. So I hope the lesson to be learned as well and to be analyzed on the good things and where there are some shortfalls to take forward. I can see there the digital alignment with the NHS strategy, and this is, I think, the way forward in terms of our flexibility in addressing the need for the future. So yeah, thank you very much for this over-rounded summary there. It is quite detailed. I don't want to start myself now with the question, but at this stage, I will open the questions to members of my committee, and then we'll come in as we take this forward. So I will ask the member of the committee first, then councillors and other people from the public will receive any questions. So here we'll start with Councillor, please.
Thank you, Chair. And thank you to all the officers for everything you've done over the last year, or the last 2 years, actually. It's been phenomenal. So, Natalia, you know what I'm going to ask. Vaccinations.
Yeah.
Vaccination pilot, the childhood vaccination pilot, still feel that there's more that could be done with schools.
Mm-hmm.
Not just our schools, but the private schools. We have international schools, we've got the Italian school, we've got the Ukrainian situation, we've got the Afghan situation, we've got so many different cohorts now that I really feel that perhaps with more and more children coming in and going to our schools, that there must be something we can do when people are registered for school like they do in France. You have your carte bleue, you can't start school if you don't have your vaccinations. So again, a key.
I agree.
I know.
Yeah, I agree with you. So I think this again, it's shown us where we have gaps. It's we've learned a huge amount about vaccination and some of the reasons not people choose not to get vaccinated. Those conversations we had with residents, obviously those were the adults, but we're seeing in the stats that as you get into the younger age groups, not just school age children, but 18 plus, 25 plus, it tapers off quite noticeably. So you've sort of then got to do a bit of a deep dive to understand exactly why is it that an 18-year-old is choosing not to get vaccinated. Obviously, that much easier when children are younger to have those conversations with their parents. But once they reach 18, it sort of then becomes their own choice. I fully support it. I think we definitely can. I know the team are incredibly busy doing all the other things we mentioned, but I think in the next council year, it's definitely something that we can really pick up on.
Can I add something to that?
Yeah.
I think the pilot's really exciting because we've been really pushing for this for NHS England and they haven't been prioritising it for us. So we finally got them to sign up and agree to this 5-hour pilot, and I'm really excited about it. I also think some of the learning about this revalidation and the stuff that we've been doing with the coronavirus. I think we've also got a cohort that are having their private vaccines once on our data. So how do we learn from that and do something similar for this cohort as well? There's a high percentage take of private paediatric care as well. So it's like how do we learn from all the learning we've got from the vaccine programme into our immunisation space as well. But yeah, definitely watch this space. Very excited to see what happens with this pilot. And I would imagine we'll see sort of private paediatric with those that are not being vaccinated and just simply an access issue, and what we're going to do about these 3 areas.
So will that come into the pre-defined transformation plan as well?
Absolutely. But we need to be like specific, which is why we've got this extra money coming in.
Excellent. That's reassuring. Councillor Woodger?
Sorry,
Councillor.
I want to ask a question on the same subject.
Okay,
Because
please.
I don't think you quite answered the point that Councillor Adam was asking about, is making use of the schools. Now, it's obviously very good we've got this money, but I would like to have seen or to hear from you how we're proposing to spend this money. And I absolutely agree that the schools are key to this. And what the cabinet member said is true about difficulties that we have with those of 18 and over. The simple answer for that is they think they're immortal, so it doesn't really. It's not relevant to them. But children in schools and parents, I think, is what I would like to see is the schools as a matter of just normal procedure is to ask parents to fill in what inoculations their children have had, and to ask and if they haven't had, to ask them if they haven't, because I actually think, and I think I was trying to say this last night, the relationship between schools and parents. Schools are very much valued, and in my experience at primary schools is that to an extent, parents who are not otherwise involved with the state quite often turn to schools for assistance, or they look to them as an authority. So I think the natural authority of the schools should be used, as I say. What have you had inoculated? What have you had, and what have you had? And I'm the last one to try and add to the burdens that the schools are asked to do an awful lot anyway. But to an extent, we're pushing at an open door here. I'm really glad to have the money, but I would like to know a bit more if anyone has any ideas now as to how we're going to spend that money.
I think it's worth bringing it back once the pilot's been worked out. We suggest to bring it back to the further writing with our NHS colleagues as well.
Right, thank you. Thanks, Councillor Woodger, please.
Oh, thank you. It mentions in the paper about the potential purposes of the Notting Hill Gate police station, or at least we're bidding to do that, which I think is a really good thing. I think as a committee we should highly endorse that. Obviously, if we were to get that site, what sort of services could you deliver when it comes down to social care there? And do we have any other opportunity sites as well? That sort of thing.
Yes, and I'll avoid politics. any site in the borough that could offer housing for people with learning disabilities is something that I'm very pursue. We obviously have identified the site because it was put up for sale. We are working with Kim Taylor Smith to now recruit to a post that will focus entirely on finding housing provision within the borough so that we can bring residents which are currently placed out of the borough back home. That's going to be a huge piece of work. It's obviously, I believe we have 64 people out of the borough at the moment. Not all of them will want to come back, that's absolutely fine. But we have to build that provision to make sure that those that do can, and those that are coming into the service also have the opportunity to stay in the borough. So the Notting Hill Police Station, in the current iteration, is looking at around 20 units that we'd be able to offer in very high quality accommodation with areas of communal space, nice little outdoor area as well. But beyond that, there are other buildings that we are sort of keeping an eye on to see what we might be able to do. I think we have to be quite proactive as a council that it's not just the right thing to do, it's also economically the sensible thing to do, because it is more cost effective and it is better for our residents that their care is monitored and controlled within the borough than from afar. Not to say that there's any risk with those people that aren't in borough, but I think we just know that we can do that much better once they're within our borough boundaries. I think I'll ask Gareth to add a little bit more flavour to that. Just there's the rest for me to say is that yes, we are pursuing other sites that may become available, and also sort of looking at ways that we can perhaps use our existing estate to be that much more efficient, to make sure that as needs change, we can change buildings to fit them as well. Gareth, I don't know if you want to add a little bit more about why we would be looking at in-borough placement.
Yeah, you've covered a lot of points there, but Councillor Kamali was very clear to about the importance of making sure that we are looking to acquire, refurbish, requisition, whatever we can do, keep an eye out for additional properties, because we've developed this better understanding of demand and how demand will change over years. And I said a bit of this to the committee before, but in addition to the fact that there are a number of people, particularly in residential placements, who are borrowing. Some of whom might wish to come back, but some will be comfortable in their placement there and won't want to be back. That's one opportunity, and people to go back to places in the borough we can create. But the other is that we know that the numbers of children and young people who will be coming through transition routes, we will need to find and create the right type of accommodation, which might not be the kind of accommodation that we have, depending on their accessibility needs, depending on their potential to progress through to genuinely independent living rather than sports production. We also have, a happy outcome, which is the people who might not have had a length of life in the past that they have now, live longer. And so people can live at home with their families, so their families get older. That setting is no longer appropriate. There's an increased demand for that type of situation where you have working age adults but accommodation is required. At present, in terms of our supply and demand levels, it's very finely balanced. And what we can do at any point in time, we might be running 2 vacancies that we're able to fill very quickly. That's across the 5 hub. So knowing that demand is going to increase over the next 5, 10, and 20 years, building, acquiring, creating those new schemes is going to be vital. And we're doing that as part of the acquisitions that Councillor Kamali mentioned, but also any developments the authority is undertaking generally. We effectively don't put down the market to say the part in the ground for those.
Can I ask a follow-up?
One second. On that, regarding the increase, is there any figure, percentage-wise?
No, I can share them with the committee.
Please, yeah. Thank you.
Can I?
Yes,
I think there was about 5 children coming into adult social care every year, so roughly about 4 to 5. So when they become 18, they are coming into the adult social care. Like Aaron was saying, it's about giving them opportunities in life, like you and me, everyone here. But the parents are getting older, and what they're saying to us, what could happen after they go. But, you know, that's what they are telling us. So we need to be able to give them hope and prepare something available for them. So mainly the need is about shelter. So that is the housing for long term. So that is the strategy that Councillor Marley was earlier saying about the building for vulnerable people. So that's what we're doing. Looking for buildings, looking to refurbish any buildings which is there, and looking for new sites to build accommodation for them.
Or redundant spaces. I'm glad that you are working with the housing on these initiatives.
Yeah, we have to look across the entire council estate.
Excellent.
And future sites.
Yeah. Thank you, Mr. for that clarification. Councillor Woodger, then Christine.
Thanks. Yeah. Just
Councillor.
it may not be really for this committee, but it is a question in terms of the housing type, because we're a patchwork with loads of different types of housing. We've got council housing, housing association properties, quite a few different ones, and obviously people in their own homes, privately owned. If someone increasingly coming across issues of people in housing association properties where their accommodation is not suitable for their needs, does the council get involved in getting housing associations to offer more appropriate types of accommodation, or does the council provide it itself? I'm just trying to understand the distinction. Where are the lines between council type, council property and housing association property when it comes to provision of housing that's suitable?
Been asked officers to answer.
So yes. So if someone lives in a council property or housing association in need of some adaptations for them to continue to live, then we have a service called occupational therapists. So we employ them. So they go out, do an assessment, and make recommendation for minor and major adaptations. If that property is still not suitable, then we work with the housing association for them to transfer to a suitable accommodation. In some cases where the accommodation will need to change from one place to another, so for example, someone older and they need a lot of care or supervision, then we need to transfer them to shelter housing. Or warden control flats. So that also will facilitate that to move on to the line. So residential care is the last place we want them to go. So we will support them as long as possible to live in their own homes, if not another home.
That's very good.
Thank you very much.
Christine.
Just two questions, really clarification. Can you tell us what's happening about the change of funding on discharge to assess, and what impact that is having on the people involved and also on your staff? That's one. And the other one is, could you update us on what's happening about the extra care housing at Lots Road, the timeline, and what range of patients that service users that serve?
Yeah. I mean, on the Lots Road side, it's obviously we're looking now at going out to the development partner to build out that whole area. There's a design brief that will be part of that. It will deliver 65 extra care units. That's exactly what we're expecting from the development partner to do. I think we're also just sort of making sure that once that's online being built, we have to plan around it, because we don't want to build this and find that it's empty. So we need to make sure that, and this will probably be for Gareth to explain more, but to make sure that we are planning ahead to see who will be coming through. I personally am very open also to working across the borough with Hammersmith and Fulham, as the rear of the site is actually owned by their borough. So even if we built there, technically they would have the nomination rights. I think actually it would make sense fundamentally, because they need space as well, and given that it's literally on the borough boundary, it would also offer us the flexibility of working across bi-borough, tri-borough as it was, to see who might be best placed to move into that site. I have to not expect.
Yeah, just in terms of and we've been doing some work, as Jen mentioned, on a design brief to make sure that on the footprint that will be available, we've got the right flexibility configurations. So with the 1 bedroom plus, rooms that are designed to have a standard to enable couples that are visiting the 1 bedroom properties as well. And the right proportion that will be way above any of our existing design guidance for wheelchair accessible accommodation within the 65 units and communal space, mobility scooter charges, etc. We're in the process and make sure that the allocation of numbers, not fit out by design, etc., but the spaces are correct. In terms of what Jem said for filling the place, starting with 65 units is a challenge. So you won't be able to move everybody day one. What's quite common with extra care schemes of that size is to use what's if you think that that's like a Venn diagram across people who may be eligible for shelter or community supported housing and people in extra care. You usually might start with a hybrid arrangement in extra care for people who may be thinking about the next steps for them and planning to move on from sheltered accommodation or HLP accommodation, people who receive home care packages, to start building up the occupancy. So it might be quite good to start with the plan on the extra.
Thank you. Again, can I jump in and ask a supplementary
Can I ask
about this?
1 second, please? Quick question, not comments.
Oh, well,
Okay. Kensington, please.
So what we're talking about at Lots Road is to replace the care home that was closed on Doghouse Green some time ago. I mean, I'm very pleased that it's going to be as up to date and as it appears to be. But why has it taken so long? We already own the site. I just don't understand why we haven't started construction.
I think one of the answers to that is events. Events is the comment, but it's been a very busy last few years for this council. There's been an awful lot of things that the councillors have to deal with, and rightly. It has never not been the plan to develop that into a care home. That's always remained absolutely a priority. You'll have seen also the sort of development around Maxilla as well. There's been a step change in the way that we do our consultations and our engagement with residents. This is the same. We have to make sure that we are engaging accordingly. It's obviously also now part of the house building program of the council as well, part of the 600 units. So there's the work that's gone on with their delivery boards as well. I myself am slightly frustrated that we haven't got spades in the ground that much sooner. But that said, I think it would have been imprudent for us to be focusing on building a care home whilst our care homes were being so well looked after during COVID. The officer resource and time it would have taken would have detracted from the service that we're offering. As I mentioned, we are recruiting somebody to focus entirely on these sorts of projects, and it wouldn't have made sense to take officers off of the existing COVID response to tackle it. That said, I agree, we need to get it built, and it's something that we are obviously committed to doing. Going to the delivery partner will give us those dates and times that we're looking to see. And I look forward to cutting the red ribbon sometime very soon. But I think you had another question on discharge.
That's a very good question. So I know my colleagues are here from NHS, and I must say that we've got a really good partnership working with our head colleagues. We meet Julie and Jamie's here, and James is here to look at the discharge process. Discharging people from hospital is a whole system, of course, that we need to work together with health and discharge people. The guidance was issued during the time of pandemic to ease the pressure on hospitals to create capacity. So there was a process called Discharge to Assess, so it's called D2A. Basically, people who are medically optimized and ready for discharge, we discharge them, and we receive funding from the NHS to
6 weeks and then 4 weeks of when they discharge to a care home. And we've done quite well in Balboa. Like I said, we've got really good rolling system with the meeting, etc. Regarding the funding, I know any colleagues are working on us because the funding expires in March, but I'm sure we will hear about the future funding for that system. We put an internal structure in place because we have to react to the emergency or crisis of COVID. Now we're looking at changing the structure of the hospital services fit for purpose for the future, because they're very likely to be the D2A or discharge process here to stay. It's the right thing to do. We don't want people to end up in hospital, not necessarily. They should be at home, so it should be in the right place to get the care that you need. So we're working on a system, make it more smoother for patients to be discharged from hospital. Funding is being discussed, and a decision will be made very soon.
How soon, sir? This indication.
Jane, do you know anything, or?
I mean, not the direct fixed date, but just
I think this decision is very likely to be made in the next few weeks.
So it's soon. Okay. Yes. Thank you. Yeah. Thank you so much for that. That's really
Yes, thank you. I'd like to ask, because it's obviously a wide-ranging paper, about the autism strategy. And really, and I think you alluded in the context of housing that young disabled people, which I include autists as also in that group, and catering for the housing needs. But I was thinking particularly of the young adults who are living at home, and you can have the main strategy you like, but what improvements are there going to be in support for them and their parents in the near future as a result of this strategy? What changes can we expect soon?
Well, from the property side of it, we've been trying to work very hard to acquire Abbey House. I know that's been fraught with difficulties around leases and fit out and things like that, but I think we still remain committed to doing that. As for sort of services, I mean, obviously we are commencing work at Maxilla. We want to get that space in the ground very soon as well. There'll be the sensory rooms established there. I think it's also just really just offering more sort of opportunities within the community. So part of the strategy was around activities that they can sort of come out of the home, go around the borough, see some of the things that we have in really safe spaces. The Natural History Museum, for instance, is already becoming autism friendly. I'll be going along there in the next week or so. And it's sort of working in partnership with our big institutions and our organisations to make sure that residents have sort of
autistic people to live independent healthy lives, which is the bit that features the accommodation aspect, but also, as Councillor Kamali said, wider than that, because access to employment, support through floating support services, for example, people to be able to live independently, generally into accommodation. And one of the things that this strategy does is try to encompass the wishes and ambitions of all autistic residents. And when we talk about secluded or residential accommodation, we tend to be generally talking about residents with learning disability or autistic. And a lot of the focus on here is on autistic adults who may not also have a learning disability, which is why the focus is largely on things like floating support, general use accommodation, access to education, training, employment, and participation in civic life. So this doesn't say much in the strategy specifically about living accommodation, but as Councillor Kamali said, the discussions we've had previously were where, in particular, there's a dual diagnosis and a disability.
Yeah, thank you. Just following up on this one, regarding the early recognition of autism I mean, how clear the process, the one we have, in order of identifying the autistic condition, and how do we have a measure in place to overcome the cultural awareness? Because I mean, I know it's not a straightforward recognition, because I know some families who will recognize their children later on, but if they diagnose them earlier, what kind of support do we have? One, and two, what kind of link with other stakeholders we are working with on the other than the autistic societies or schools, because this is another mechanism to have in place where teachers they can recognize certain symptoms. So how closely we work with these early stages of recognition?
Obviously, I'll refer to Autism on the more technical side of that, but I think something that the Autism Strategy highlighted to me was just how underdiagnosed it actually is in the United Kingdom. I think it was mentioned about the diagnosis rate within the United States of America and how it compares to us here in the UK. I think they were an order of 5x greater than we were, if I'm not necessarily mistaken. But I suppose also part of the strategy is the fact we have a strategy and that we are highlighting this to our residents. The Citizens Plan panel, for instance, showed us that nearly 10% of our residents were aware we had a dementia plan based on a proportional sample. Obviously, that should be far higher. But if we can do the same with the autism strategy, then it becomes part of everybody's psyche. They'll be looking out for those things, especially as you go about your daily life. As for the actual sort of diagnosis, I'll ask Gareth to answer.
I'm not a clinician, but one of the points that's made, another one of the pillars of the strategy is around what we can do better about early identification and diagnosis. That's a London-wide challenge, and there are London-wide initiatives that we're part of to do that in partnership with the NHS, where the diagnostic services primarily lie. There's a good example in the strategy from one of our residents, Charlotte, who talks about her experience of early adult diagnosis that hadn't been identified when she was younger, and some of the challenges that posed for her throughout education, but then I was able to move on into higher education, and people with achievements having had the support from the adult diagnosis. The strategy doesn't at this point say these will be specific things that we will do locally. And that's what the Autism Partnership Board is going to help us to then transpose into actions. But one of the things that actually look at agenda this evening in terms of mental health wellbeing in Kensington, that we learned through some of that community practice and activity is about supplementing statutory diagnostic pathways and work with access routes that are community attuned, community specific. And we know that through the work of things like this Together for Growing Collaborative, that have helped people come in towards mainstream service who might not have gone through that direct route use. So a lot of people learn from work we've done in other fields to try and increase diagnostic rates that take for autism.
Thank you.
Sorry, I just want to go back to accommodation, and Jen, you briefly touched on Abbey House, but presumably you're looking to increase the provision for respite care because it's such an important thing for not just the individual but for their families. Is that something that could also go to Notting Hill Police Station? Or
in our sort of current working, it's yes would be the answer. I think there's no the designs for that site. We don't even own it yet. Obviously, we still have to wait for the mayor to sell it to us. I think the conversation for that site is that it presents a wonderful opportunity to see what we can do there. It would be a large, very rectangular site. It makes it very easy to fit in exactly what you need in that sort of jigsaw. Again, I think sort of something around a hybrid model could be possible, where we look at the way that we operate that site. Again, you can't build it and immediately move everybody in one day. So perhaps we sort of phase it in. We also have to discuss with people, look at the care needs of those that are out the fire at the moment. Yeah, I think nothing's off the table. Obviously, we have to have it in our possession first. But the same goes for every building. I think it's not every building will be perfect for every option. And we have to just be nimble that if the building presents itself, we get it. And then we have myriad uses that we can put it to. And we just have to sort of make sure that if it's small, then perhaps it is only a few beds and it will have sort of slightly more independent living. If it's much larger and we can accommodate staff as well, or have even live-in carers, then that's what we'll do. But obviously the ambition is there. It's just really making sure that we find those relevant sites. I'm looking forward to the year to come. We'll have somebody dedicated out pacing the streets in Chelsea.
Right. Thank you. Any member of the committee? No? Okay, now I will invite the councillors who are not members of this committee, if you don't mind, who are present maybe in this room to ask their questions. Councillor Healy, you like to ask questions?
I think everything that I wanted to discuss has actually arisen, so I'll hold my part for the time.
Thank you very much. It's nice to have you. Anyone? Any colleagues who are present here, they heard what we've been discussing, you would like to comment or any further observation you would like to clarify with us? No, thank you. And people online who are joining us, welcome. Do you have any comment of what you've heard from us so far? No. All right. Thank you very much. That's extensive. I'm really grateful to all this work and the commitment. I can see the future there. There's plenty of lessons to be learned, and it's only to strengthen our relationship with the NHS, who we greatly appreciate all the efforts they are putting for our safe environment, for a safer borough, for our residents, and hopefully the other stakeholders, including maybe universities. There are some research going on there. Hopefully we can extend as part of active stakeholders to be involved with us, especially on the public health dimension. I have no further things to say, except to thank you for coming to this committee to present your report. Thank you so much. Thank you. Now we move to item A5, which is the NWL integrated service. We have a report from the Northwest London Integrated Care System on the review of palliative care services in Cambridge, as we requested earlier. I would like to welcome Robin Doran, the Chief Operating Officer for CNWL, and colleagues to the meeting, and to introduce the report. When you settle in, welcome. I will appreciate we have a brief introduction to those who are present with us in person or online, and give us an overall view. So, welcome.
Thank you, Councillor. And it's very nice to be here. It's a long time to see you in this room. I've spent many hours with many of you in this room over the years. And I'm here with a different hat on today. So I'm here as the SRO for the Palliative Care Review. So I'll get maybe my colleagues to introduce themselves, and we'll do literally 5 minutes, and we'll be open to questions.
Take your time.
Jane?
Hi, I'm Jane Wheeler again. I've met many of you with different hats on, but I'm here now in my UNTS Programme Director role for local care, and that's the programme which focuses the work on end of life more widely in this review.
colleagues, James Benson. I am the place-based partnership director for Borough. I'm the chief executive for Central London Community Healthcare, and I am the SRO for local care for North West London. Welcome.
Hi, I'm Philippa Johnson. I am the Director of Operations for COH.
Good evening. I'm Dr. Lucy Williams. I'm a GP, but I'm also the clinical responsible officer working with North West London ICS and supporting this group.
Thank you. Now I turn to our colleagues online.
Nobody online's for that. Not
No?
for that. That's for the next one. So it's my team.
Ring the bell. Look up. I thought we have some people.
That's the next item.
Okay.
That's the next one.
All right. So
this one's about palliative care.
Right. Yeah. Thank you.
So first of all, thank you very much for inviting us today to talk about an incredibly important subject.
Yes.
So the North West London ICS wants to work with RBKC, with patients, the residents, and many of the other stakeholders across the system to look at how we understand how we can improve the experience of all of the adults who use community specialty palliative care services in North West London. We established a North West London steering group that consists of providers, hospices, local authority, resident and carer reps. We have an issues paper which we have submitted, which sets out the key reasons why we are looking at specifically the community-based specialist palliative care, and helps us have a conversation on what future care could look like in terms of what people are looking for. We started the process in the 18th of November. Unfortunately, due to Omicron, that kind of stalled us a bit in terms of some of the dialogue and the consultations, the discussions we were having with various residents. So we've kind of kick-started that again, and it was extended to mid-March. During the winter, key partners were largely deployed to the immediate response in terms of Omicron, which you can, I guess you can all imagine. I think the other thing I just wanted to acknowledge that we have had a letter from Councillor Kamali, specifically around the Pembroke Centre, and actually some of the points that we'll pick up and my colleagues will pick up in our introduction.
And Robin mentioned there that the engagement around the issues paper may pause in the middle of March as we go into PERDA, but actually the whole way we want to run this work is engaging continuously and having that dialogue. I sat with many of you round tables 2 years ago having these conversations, and the things I heard are still valid, that we need to engage widely, we need to engage meaningfully, we need to be clear that we are acting on the feedback given and that we are taking it seriously. You will also be able to see that we are publishing the kind of what people have told us and what we're doing about it on our website. We will continue to do that, so you can see where we have been able to act and where we know we've still got more to do. We're meeting North Kensington Health Partners next week, by example, and the organisation we're meeting with. This isn't formal consultation at the moment. This is really us hearing from people, so we get this right at this stage and we do it in a measured way with you. So when people are asking us kind of questions about the information they need to inform this process, we're responding to that and sharing the information. So we really hope this is setting us up on a way of working that is very transparent and open with you about the stage we're at, what you're telling us and what we're doing with that information.
Yes, thank you. So specifically members will remember, and I was previously here before in my roles too. The Trust took the decision to close Cambridge on the result of not having sufficient consultant leadership of that service, and that we decided for a safety reason to close the unit. I had previously discussed before here that to run an inpatient unit at 13 beds required significant consultant input. We didn't feel that it was safe to continue running that service. It precipitated a series of events that colleagues will remember. And whilst we had this service closed from an inpatient point of view, we continued to run the 24-hour service. The advice line continued to run, the palliative care specialist teams in the community continued to run, the bereavement service continued to run, and that has run the entire way through the COVID period. To note though, members will reflect that in April 2020, the inpatient beds at Cambridge were reopened, but not as a specialist palliative care unit. We opened those in regard to the management of COVID, and as a rehabilitation centre for individuals with COVID or recovering from COVID. The decision to do that was taken by the Trust in conjunction with North West London ICS to support flow and support flow specifically for the residents, not only of this borough, but also other boroughs in
West London.
So we do recognise that local residents are extremely disappointed with the need to suspend the inpatient units at Cambridge. And we stated in the report that the review of that decision will take place following the completion of the review. So that is obviously currently underway, and the engagement sessions that are planned will take information from local residents around that, and noting the letter that we have received that Robin mentioned. So we really want to confirm today that both qualitative factors such as local accessibility and stakeholder views are important considerations in that, plus quantitative factors such as referral rates, capacity and demand, and what we need in terms of special-based community services will be all part of that picture, and therefore the future of Cambridge inpatient beds as part of that picture.
So clinically, we've seen what a difference specialist palliative care can make, and we know that. But unfortunately, we've seen what happens when care and support is not on time, and the damaging legacy it can leave for those left behind. So that's why it's important that we work together and we develop services of a high clinical standard, but also that meet the family, the patient, the carer's needs as well.
So we know that more people die in hospital than want to. Actually, most people want to die at home. We also recognise that there's inconsistency around this, the different communities that we serve in relation to the variety of communities that we have in North West London. So therefore, part of this process is actually about going out and talking to those communities, coming here, talking to scrutiny committees such as yourself, and really listening to what you're saying about what we need to do differently. And from that, we will pull together a report, and then we'll make some recommendations, and we'll then come back to you. So that's it for us. We're very happy to have any questions or comments that you want to make.
Thank you so much, Robin. That's really assuring, and that it's quite a tough decision. And as James outlined, they review and the impact, and you are being guided by different measures. And I hope this as well as sensitive measures. So I hope the right decision will be taken. I know it's being used effectively at the moment during COVID time. Yeah, thank you for all the efforts to engage with us and provide further clarification and on qualitative as well as quantitative measures. We'll open now the questions, if you don't mind, to the committee members. Councillor Williams.
Yes, two questions. The first is a very specific one from Mr. Benz. I think a number of us here are concerned about the future of the charitable funds for the Pembridge Centre, and which is a dedicated fund. And I wrote to your organisation about a month ago, and the only reply I got was saying this is being treated as an FOI request, which is not really what I expected. Can I please, I don't have to debate about this tonight, but can I please email you tomorrow and can this be dealt with properly? Thank you. But my question, really, I'm trying to get to the heart of the matter on the Pembridge unit and the need it was serving. I mean, these options, you're talking about funding the same number of beds. But I mean, what is the position at the moment? I mean, I think you're saying that you really need more, we're still trying to get more information on how people from particularly North Kensington and adjoining areas who would have gone to use the beds at the Pembridge Centre, I mean, how are they being accommodated? I mean, are people and are relatives finding they're having to travel much further to visit their loved ones in their last days, and would have been the case when they were at St Charles? I mean, there's no feeling in this document as to what's going on here, how things changed for individuals as a result of the closure of these beds.
Redirect to Jane, business down.
So as you would expect, we have been looking at patients who would have been admitted to Pembridge but have gone to other inpatient units. It's quite difficult to tell from the last 2 years. As people have made allusion to earlier, it's been a strange 2 years. We've seen hospice activity everywhere is different. Lots of people have been more reluctant to go into inpatient settings. So the numbers that we can see over the last 2 years going elsewhere doesn't necessarily reflect that true demand. So we didn't put the figures in the paper because we don't think they are fully reflective of the deflected demand as it. And we also know that some people may not have made those referrals knowing that the site was closed. So we do have that data. It is much, much lower than the activity that was previously in Pembridge, and predominantly that activity is flowing over to St John's.
Yeah.
I know there has been some comments around down to Trinity, but largely activity from this way has been going over to St John's. But as I said, it's much, much lower than what we saw going to Pembridge previously, and probably not reflective of the full demand.
I think the other thing that members might want to reflect on was because we had stood down the service and redirected the staffing into the community, the level of activity in the community to support people at home by virtue of specialist palliative care has therefore also increased. And part of the challenge of that is similarly we're also dealing with the COVID numbers as well. So we're just trying to work therefore through who we're seeing for what and what does that look like in terms of future modelling.
You should probably put that in the paper because I think that's actually very important, because my position has always been all these things that you are talking about improving and keeping people in their homes for as long as possible. None of us are going to disagree with that. But what I have not understood, and perhaps I start to understand it from that last answer, is it seems to me what our residents want. They want all of this, and they also want back the local beds. Now, for the first time, you're actually, I can begin to see possibly what you're saying, that by not having those beds, you've been able to improve the, please, you should have said that. We might actually then take it seriously, because otherwise, I didn't mean to start at this point, but having started, I might as well carry on. It seems to me that all you're offering is yet more consultation. Now, I recognise that the last 2 years have been difficult, but I mean, I was absolutely amazed that there's a statement in here saying that page 10, we're not discussing current community-based palliative care or what the future could be like. Well, residents actually want you to do that. As I say, there's no disagreement as to the improvements that you're going to make. And one reason, I was going to start off by saying something nice, so I'll go back and say something nice at this point. This paper is better than what we had from you previously, because at last you begin to seem to be recognising what the residents are saying, which again, to repeat myself, is we want all of this, but we also want local beds. And as you say elsewhere in this paper, or maybe it was in the previous one, we have a growing elderly population. You finally recognise that many people around here live alone, and it's a lonely community. It's not like it is in other parts of the country. I'm not at all surprised that you found that nobody is going south of the river to Trinity, because as the residents told you, and as we've told you, communications are difficult. It's an hour and a half to get down there. It's still not easy for people from Kensington to get to east. So it's better, but please, it's right to consult people, but we sometimes feel that it's death by 1,000 consultations. The longer this goes on, you're hoping that people will forget how much you value. We value the local service, and it has been said to me, though I'm not saying it, that this process of keep consulting people is like we find with developers when it comes to planning. They come back and they say, we hear what you're saying, we're going to take it away, we're going to make a change, and then it comes back again. And in the end, the hope is that you will exhaust those who are the very strong feeling in the community that we want those we want those beds. And as I say, the analogy with what developers do, it has been said that you're just hoping to exhaust us all. Now, and I go back to saying that this paper is much better because you do finally start to hint at, or well, show that you understand where the opposition is coming from. And nobody has said we want things to stay exactly as they are. As I say, we genuinely welcome this improvement and for people to stay at home for as long as they possibly can. But at the end of the day, as you said, people don't want to die in hospital. And the idea of people dying in acute beds is a huge waste. It's not what people want. But as an older population, people taking longer to die and decline, unable themselves, as I think you said in the previous paper, unable to take care of themselves, they need to go somewhere else. So that's why there is such passion over the 13 beds at St Charles.
Yeah, thank you, Councillor Atkinson, and thanks, Robin. I mean, yeah, the sensitivity there as well, and we recognise that COVID has really posed perhaps time for us to think or rethink, and replanning is no harm. I mean, it's better to get it right rather than go to waste all the other activities, and as I said, to reflect on what can we learn from this whole bad time during this pandemic. I will call Councillor Atkinson.
Thank you. One of the areas that concerns me about this whole decision-making process is that during the original review, which I think started in 2018, only 48% of people made contact. Now, we've just had 2 years of people avoiding or not making contact with the health service. So what are the numbers now? We don't know, I'm assuming. So we're making a decision on numbers we just don't know.
So once they make contact, yes.
So on page 18, appendix 1, page 18, any policy of access to the services, I remember this specifically, with only 48% of people who have expected death having any contact with palliative care services. I remember it came up at that big meeting. Do you remember?
Yeah.
People saying, well, we didn't know. We weren't. But I was just saying, because you'll probably want to do both, is again, it's the respite care, but not just the patient, it's the family. You know, if they are living at home with their family, just having a couple of days without that person at home makes such a difference to the family.
So I think if we go back to the original document, what we were setting out was that we were not seeing all of the individual specialists. We would have benefited from specialist palliative care. Because historically, specialist palliative care was largely used for end-of-life cancer care, not for the broader sense of end-of-life. There was an inequity in terms of the delivery of specialist palliative care. And that's not just a Royal Borough position, that is a large position across the country, because we had historically seen it as a very specific thing. Part of when the beds were closed and we repurposed the staff actually into the community and kept them in the community, we have been able to provide additional support to people. The point that I think Councillor is going to is the respite part. And this is a very important part in terms of, if I go to my point as a place they lead, it's about how do we provide support to people in their own homes to provide care and support for them and their family members and their own carers. The very specific point that we're probably going to find very difficult to analyse is how many people could have gone into a hospice, because the numbers around individuals who are dying with COVID are also going to manipulate the numbers. So, which is why I think we're in an awkward situation. To Robin's leadership, we need to go back around and restate what the historic argument was. Listen to people again respectfully. Whilst Janet and I have discussed this with Bernie specifically in our leadership for the by borough, I know only too well what colleagues and our members of the public said. I'm not entirely expecting that to be any different, but we respectfully need to re-ask again. We can then look at the levels of activity and then, through Robin's leadership, lay out what we think a new model could look like, and then go through the normal process, which will pick up how many respite beds might one need. Where should they be?
So I think what's also different about this process, and I wasn't involved in the previous process, this is across all 8 boroughs. And so it's looking at, so I'm an ICP director for Brent. So Brent is a really complex borough. I know North Kensington and the borough here is very complex as well, but Brent is hugely complex in terms of diversity of populations who get very little access to some of the specialist palliative care services because they don't know how to access them, or they're not very accessible locally. So there is a whole piece of work across North West London as a whole, but each borough and each place has been asked to look at what are the, a bit like James has just referred to, what are the specific needs for that borough? And obviously the Royal Borough has specific needs because of the populations that you have, and because of what you've had here before. That hasn't been the case in Brent, for instance, or in Ealing or in others. So this is an 8 borough wide review, whereas I think the previous review, as I understand it, was 4 boroughs and specifically looking at issues such as the Pembroke Centre.
I think that means you want to come in.
No, I was really reflecting on, I think, colleagues, so talking about the paper and how important it is to communicate clearly and not just a talking shop. Let's not, I think lessons learned, I am proud of what we've done. A lot of hard work has gone into this paper and a lot of clinical review and our carers have been part of this, as Robin mentioned. And I think, I'm hoping that reflects on this paper that you're reading. I feel like it does. But I take your point, and I think that we've seen a lot of opportunity and great improvement from this that I feel that this paper has missed out. Like the activity we're talking about, the community activity. We know patients' needs are the priority. The patients are in their needs and their family and carers. And we know the activity for the community has gone up exponentially. But I feel like we haven't quite shared that, and that's a shame. But so I think this is really important that we've done today because we're a great addition to that paper.
Thank you. That's right. Interesting. Yeah, thanks for that addition. Christine.
Yes. Going back to some of the points that were made on the 13th of December last work consultation. What patients were saying very positive from their experience was that you have to consider community sessions in conjunction with inpatient beds, because there comes a point in the trajectory very often when the family can cope no longer, and there is the safety is the knowledge that some of the hospitals will step in and provide care when the between teams. Yeah. So that point has been made very falsely. And people were also saying that asking people in advance where they would like evidence. But when it actually comes to the point with a complicated illness, that is very different. So that asking people in advance is probably a bit worthless. So, I mean, those are some of the points that were being made. So I think sort of in answer to what Councillor Atkinson was saying, it's not that we want to have our cake and eat it. It's that we want wraparound care as local as possible. So that there is the possibility of people feeling that they have the ability to go on for longer, if there's people who have that, but that somebody will be there for them at the point that they can't. That's just an information. Question is about funding, because Pembroke was NHS funded. The hospices are partly charitable, and I just don't know if the hospital what was ever said. What the breakdown is, I mean, how much of a bed in St John's or Trinity is actually funded by the NHS, how much is it charitable? Because we all know also that donations are falling off, the economic crisis that we're in, and that charitable funding is a real issue for the hospices. So there's reliance on two very good hospices that we have, but not locally. How sure can you be of that?
So if I comment on the patient stories first of all, and then maybe Jane might say something about the funding. So I think you're absolutely right, and I remember those stories very vividly, and I followed up with one of the young men who gave his account of his caring for his mum at home, and she changed her mind. She wanted to die at home. She was really clear about that, and they had a very clear plan. But what he said very eloquently was that she and him, at the end, decided that actually it was too much. What happened in his case, because I followed up with him and interviewed him, and we then followed it up with the hospice, because we're not stopping to the end to deal with some things. We're literally following up on them. And his name was James, and he wants his story and his mum's story to be part of the review. So we will be doing that. We'll be telling the stories that we've been given from some of the carers and the patients. And actually, we will say what we've done about it, because I think that's really important. And you're absolutely right, it changes for people. So at the beginning, it's really important to get a sense of what do the family want, what does the person who's dying want, what do the carers want, but recognise that will change. And actually to keep asking, to having those conversations. So definitely, but it is important at the beginning to ask what people want. That we can't assume that people want to be at home or in a hospice, because actually it's going to be different for different families. And as I think Councillor Atkinson said, people live at home, and there's lots of people who live at home, and they won't have that opportunity to die at home, unless we've got some care in, but even so, that's highly unlikely. Jane, do you want to comment on the
dry money bit?
Yeah.
Brilliant. Take your point in reverse order, because the second one's a really easy answer, which was we were really anxious about our hospices over the last 2 years, because many of the charity shops closed, and luckily our national colleagues were also anxious about that. There was quite substantial national funding flowed, and over the last year we've also been able to flow other funding into our hospices. And what we're hearing reported from them now is that activity is really picking back up. That charity shop income, which there's and other fundraising, but largely charity shops, is really picking back up. So that support over the last 2 years has made a minimal eating into reserves. So we are hopeful that we have a strong position going forward. The percentage of which is funded by the NHS versus the hospice is a much harder question, because it changes over time. So obviously it's been very different in the last 2 years than it was in 18, 19, 19, 20. And also to some extent, it is the hospitals to declare that to us in terms of, what comes from different commissioners, and what comes through core contracts, and what comes through their variable charitable income. And it varies by hospice from over 50% to way below 50%. So we do have that information. I think it is something we're going to have to share as part of the review in terms of that clarity. It is also really sensitive with hospices as key partners, and how that is shared, and how that informs different charitable giving views that those hospices may therefore receive in terms of impact on their revenues. So we are, like I said at the beginning, I think transparency has got to be really important in this. I remember sitting in meetings with Councillor Atkinson saying, I don't have that information to share with you now. Now I think we're starting to get more of that information. We've just got to figure out how we share that in a way that feels fair to our hospice partners and their concerns about putting information out which may say they're really well funded by the NHS, and that may impact on their revenue, and panning that through in a way that is transparent but fair. And I don't have a really definitive answer to you, but that's not because we don't want to be transparent, just because we want to be fair to the hospices too. Does that make sense?
And we know we have to address
it. Yeah, Robert?
Yeah, I think the main point is that we know that that's an issue, and we know that we have to address that as part of this review.
Yeah, thank you for that, Jane. It's quite clear. I think it would be nice as well, as you said, to follow up with further additional appendix or reports, especially on the sensitivity of the ratio of balance between so we don't want the charity status to be undermined. Appreciate it. Share with us. Any member of the committee want further clarification?
Just one small point, which Robin was talking about. You widen the consultation now to cover 8 boroughs. I'm slightly worried about that, and I'm very sympathetic to Brent. and their problems, but we've got our problems as well. And in this, you say you had a meeting sort of northwest London on the 13th of December, and 40 people attended. I mean, it worries me slightly that if you start on a wide consultation, people are likely not to assume that it applies to them, that people have to travel wider distances. And just to say, I mean, 40 people for 8 London boroughs, not actually very impressive. And I know that's not your fault. But you compare that to the number of people we had in the town hall, and I assume you're going to have it again. You have a problem. Yes, of course you have to widen the consultation, and I'm very grateful you come back to us again now. But consulting over such a wide area itself is massive problems, I think.
Yeah, and I think you're absolutely right. And I think it's not just at a wide area. So I think part of our process is to pick up, as I said, some of the communities across the system that we haven't served well. So the faith communities, people who are homeless, LGBTQI community. So we're actually looking at various communities, if you like, across the system. But each of the place-based directors, such as myself and James, have been asked to do some specific consultations in their places, in their boroughs. So we're doing something around specific groups that we haven't talked to before. Yeah. We're doing some wider events like the one that we started, because that was just the beginning. And absolutely every place is expected to run some place-based events that may be for different communities. So here, obviously, the communities are very different in North Kensington, and the neighbourhoods are very different than some of the other communities. So we recognise that the place-based directors have a role to play in that as well.
Just to follow up on that one, I mean, how are you advertising what is planned for the middle of March? Because that's quite soon, isn't it?
Could I defer to Janet for that? Because I think the first part is, and it's very specifically for our residents. I think we heard quite clearly and loudly, and I remember that. So I don't propose that we propose on words, but it's how we would just recheck some of what was previously said. Janet?
So we are thinking through exactly how we do that. What we intend to do is use existing fora at the moment to start initial conversations. We think probably there isn't quite enough time before HERDA then comes into play for us to really do an effective communication about an engagement event for our local communities. So I think it is likely that actually it would be, in the middle of May, that we would have that event now, given the timing that we are.
So I don't need to write down the 18th March.
No, that was the deadline by which we have it done, because that was when HERDA, as opposed to a date that we don't. And because obviously we now are on the whatever date it is, but it's March.
And a couple of other boroughs are in the same position. That they feel that they can't do it justice before March.
And we don't want to rush anything, and we want to make sure we've got that capturing the right people to be able to attend.
Yep, thank you very much. I will now invite councillors. Councillor Healy, please.
Thank you, Chair.
And then Councillor Kamal.
As Councillor Atkinson said in the beginning, I think this report is a huge improvement on what's gone before. We have clearly listened to a lot of things, but there are still problems, I think, which need to be picked up. I understand that the documents relating to this particular review are being placed on the ICS website, but they're not yet a legal body. And most people, I assume, will go to the CCG website rather than to ICS. And that is a problem, because a lot of people have been missed because of that. Another one, I don't know whether this is happening elsewhere, but in Hammersmith and Fulham, because of the interests of campaigners, health campaigners there, the borough is actually closely involved in the ICP, and they are developing a detailed and borough-focused programme of engagements to bring in the kinds of people that we have been talking about, or you have been talking about. And I wonder why that can't happen in Kensington and Chelsea. And my final point is that I agree with everything that Christine and Councillor Atkinson and indeed Councillor Williams have said about the importance of Pembridge.
it really does need to be said. There are huge numbers of elderly people living in them, and I'm one of them in North Kensington, and they do really need those beds.
Okay, I guess on the first point, I'll look at Andrew. It's a really well made point, and I think we'll just deal with it.
I've done it already.
It's done. There you go. Come on.
Did it? I was not here if somebody else said it.
The second point, as it so happens, Philippa is going to be directed for Brent. We kind of all have at least your brain. So she actually has led that review, and I think we're all meeting as ICP directors to learn from each other. So that's something I'm sure Janet will be talking to Philippa about when we're here. No, what I'm saying is that Janet is here.
So that was the reason why we are not doing anything between now and the herder starting. So we were able to do that, and part of the Fulham ICP as well. So actually the learning, but we are sharing all that information.
And really, I mean, if I could just add in what we're taking a really proactive approach with our interested parties and our communities to co-design the engagement session so that it really works for people, and we're sharing that. So, okay.
And your point with Cambridge is absolutely here.
Yeah, good.
So that's very clear.
If I can one.
Yes.
So interesting in our place-based conversation about how might we run this in Kensington, Chelsea, one of the comments that we had discussed was in the last very large meeting that we had an awful lot of residents from Borough and Hammersmith and Fulham. So it's how we might actually create something that's physically in place whilst recognising that we know that people may travel for some of those bits. So going to Robin's point, how we recognise different groups and how different groups might be engaged because of the nature of these environments. My last reflection, I think, is things have changed remarkably in the NHS in the last 2 years. Our ability to sit on a weekly basis with local authority colleagues and work out what we are doing and how we might progress some of this work has phenomenally changed the way we think about how we should engage, how we should work with partners. And I recognise that some of the players may be the players who were historically present, but I think there is a very different process that we're probably going to do, which is why Robin's going to be leading.
Can I just add that both Robin and Jane have a very good knowledge of our BCS and the different groups, and so we expect the best consultation. No pressure.
Thank you very much. Councillor Kamari, please.
Thank you, Chair. So as someone with a father-in-law that's currently in palliative care that's at least half an hour away by car, an hour away by public transport, longer if you have the city car in charge. What has been really clear has been just access for the family. It's respite, as you mentioned earlier. It's not so much even for the inn. It's actually for his wife and the children to be able to be home, almost come to terms with what's about to happen, but also have that space so that they can visit him when necessary. You've touched upon sort of the distance issue. I know Councillor Acton said it, and I thank officers for tempering my response that I sent you. So I am absolutely clear that we shouldn't have a consultation where the doors are already closed. It should be it should be set out very clearly what has to happen in those responses for those doors to be reopened. What do our residents have to tell you? And that should be option number one, and then follow through with all of the community service that goes with that as well for residents that want that. It should start with what has to change to get those doors reopened and those beds fully for our residents, and then the additional services that can be offered as well. You've heard me speak tonight about procuring buildings, looking at the estate, looking at repurposing sites. Perhaps there's an opportunity even somewhere else within the borough as well for this. Obviously, we've really got the facility that's there now. Please tell me what we've laid out so that our residents can make it very clear that they want those beds.
It's not considered that. So I think that is a helpful way forward for us. Part of that is understanding what the recruitment needs would be in a very difficult and challenged position. And whilst this is not a deflection, I think as part of Robin's work, we're going to see that it's not just North Kensington that potentially has service need. There are other places in with the same types of populations that we also need to think about, and therefore the historic, what does it mean for all boroughs is one thing, but actually when you start to look at that, you start to go, well, where are the other places? And therefore sites that Robin may have did, but we might go through and say, well, actually, how would we address access, physical access, virtual access? What does that look like? Would play into that. For clarity, I'm going to step into the Chief Executive of the Trust point of view. The beds remain closed. We hold the estate for those beds. We have no plan to repurpose those beds at all until such time as we have gone through, as a system, a review and a process. My very specific point about using those beds was at a point in time when I needed to use them for the need of our population.
No, we scripted out.
I agree, but it's worth noting we have no plan to use those beds in any other way until we understand what that would look like. They may not be in the right place, but it is an estate that we still hold.
And could I just offer the council support? We're looking to buy buildings. If a portion of it will be for palliative care, we can work with you on these things. You know, this is something that we're really keen to do across the piece. Let's not be in isolation, you know.
Thank you, Councillor Kamali. That's really reassuring. Working in partnerships. That's exactly what we do. I would like us to ask if any other officers would like any comments or from our guests online. Observation? No, it wasn't there. Okay, we'll accept that. Thank you so much for coming tonight to see us and provide the clarification on your report. Much appreciated. Safe journey back home. Robin, thank you so much. I saw you first time in the space when it opened almost 3.5 years ago.
It is, yeah.
It's nice to see you again. I've helped you and keep well.
Thank you.
Thank you so much.
So I'm just going to stay here. I'm never going to put my other hat on.
Yes. Welcome. Thank you very much. And I know I recognize if officers, I have been advised by my vice chair if an officer would like, they can leave and follow us remotely. You're welcome because of the issue of transport. Thank you for that reminder, Councillor Attenborough. Now I will move on to item A6, mental health in North Kensington working group. Now we have set up a working group kindly led by Councillor Williams, our mental health in North Kensington. That's a very challenging area. And the group consists of Councillor Idris, Councillor Atkinson, and Councillor Attenborough. I would like to thank the working group for all their hard work that's gone into this piece of work. I would like to welcome David Bello, who is the head of service for mental health, and Anne Sheridan, alongside colleagues from CNWL, who have joined us remotely. So welcome and very good evening to you.
Thank you, and I'm sorry to be with you in person, but thank you.
Yes, no, you are welcome. You are here already, more or less. You're welcome. So now I would like to ask Councillor Williams to introduce the report. So over to you.
Yes, thank you. I'd just like to start by thanking my colleagues, Councillors Atkinson, Addenbrook and Idris, for their help and support with this study. And very special thanks to James Darman from our scrutiny support team, who did a lot of work and particularly pulling it together at the end. And my view did a very professional job. I will just, I will go comment very briefly on each of the recommendations. And as I also add, as I said to the council last night in the context of a report from a different scrutiny select committee, it is important that, particularly some of us won't be here, May, that the committee continues to monitor these the implementation of the recommendations. I would say also that, as it says in the report, we were on quite a tight time scale. There wasn't quite the opportunity that we'd liked for involving the community. So we worked primarily with the voluntary sector, although I did approach councillors in North Kensington and certain individuals that we know had an interest in the matter, and I'm grateful to everyone who contributed, including some of those who are here today. Turning to the recommendations, but the order is just the order of the topics covered in the report. But the first one, the single point of access, this was not something I expected to come up, but it did, and it's something that I think that the SPA has been extended to include support for children as well. So it's young people. So it's quite an important service, which I think is slightly below the radar scrutiny. I hope perhaps CNWL will perhaps be able to comment a bit more on developments in that service. But as we said, I mean, the several places before, the voluntary sector in North Kensington is a very powerful resource, and therefore we hope that it can be involved more in helping those in crisis. Recommendation 2, although this report is not formally going to the Family Children's Services Committee, we will be able to discuss that because there's some additional information on counts which will be submitted to that committee as a matter of arising from the committee. The recommendation 3, the coordination. Sometimes, I'll be honest, I find it quite difficult to get around exactly all these different bodies, but I think there does need to be, without having to get more meetings, some more effective structure to coordinate efforts. Recommendation, I'm not sure if there's anyone here from the CCG, but I mean, this problem is, I'm sure, not unique to this area, that I think the support for people with less very acute mental health issues in primary care does vary, and I think the CCG did say this. They now that we're coming out of COVID, that there will be more effort can be put into this issue, and again, the committee needs to keep an eye on this. Recommendation 5, with the ending of specific dedicated Grenfell recovery funding, both in the NHS and the Council's recovery fund. I think the committee will want to look within 2 years at what is going to follow. And finally, recommendation 6, I mean, again, paying tribute to the work that voluntary organisations do. I mean, I think a number of them are community and faith-based organisations, and I think there is a slight concern that people may not may slip through the gaps because they don't belong to not associated with a particular group. So it's important that everyone has access to services provided by the voluntary sector, and those who commission them, obviously, I'm sure, bear that in mind. So I leave it to make comments or ask questions.
Thank you very much, Councillor Williams. Really, it's quite good report, and I can see from the list of people who contributed to your effort. Really, we thank them all without mentioning specific names, especially as well with the voluntary sector. I happened to meet one who really appreciated that effort, and he asked me specifically to get involved later in North Kensington, extending on these recommendations and this type of work. So I would like to ask the committee members if you have any observation to ask Councillor Williams. No. I will ask our colleagues who are listening to our work and our effort here. So it's over to you, Anne or David or Cyril. I can't see. Yeah, Anne. Okay, go ahead, Anne, please.
Thank you, Chair. And I just wanted to start off by saying that thank you very much for the report, and also for all the work that people are doing, and we really appreciate the focus in North Kensington. And it's I know that Dave will talk a little bit more about the work he's been doing, but I thought I would take this opportunity to introduce Saru, who is responsible for our single point of access and is our urgent care director, just to tell you a little bit about the work we've been doing with the single point of access, and with the additional funding that we have got, how we've been shaping and changing that. So I'm going to hand over to Saru.
Thank you.
Thank you. And thank you, Chair, for this opportunity. So in terms of single point of access...
The sound, please, a little bit, Saru. Very volume up. Whether it's our side or your side. Let's see.
Should be near the mic.
Maybe move closer to the mic, Saru.
Yes, please.
Is that any better?
A little.
Yes.
Oh, fantastic. So in terms of single point of access, we are going through transformation with the team. And as it stands at the moment, actually, I think in the report, it was talking around some of the data around the performance of the team. And we do actually have data around, our core volumes, who's referring into SPA, who's using the service. And I'll be really happy to maybe have a conversation outside of this forum with the relevant people to go through that data, so that you can also have the insight of some of the good work that's happening in the team. We do work closely at the moment with third sector organization called HESTIA, and we call that's our COVs, our crisis alternatives for patients, and we do have data around the usage of that. In terms of our transformation, there is plans definitely echoing in terms of working with our peer support workers, but also working with third sector in our single point of access, and volunteers as well. So that's some of the work that we've started doing. We recently, about 2 months ago, we had a stakeholder engagement with our carers and the service users, just to find out, because sometimes we have a perception that our service is actually offering people what they want, but actually that could be wrong. So it was really to ask, this is the offer, but what is it that people want? How do they want to access us? And that's, work that we are continuing to do. And I'll be happy to, at some point, to feedback on progress of that work.
Thank you, sir. It's appreciated. Do you want to add anything, Anne, or David?
I think I would just add in relation to our single point of access, the additional money that we've seen coming into mental health has supported us having a first response team. So as well as our single point of access where people can actually get support and advice, where there is an urgency, we have got a team that can go out and actually see people and can work with them in their own homes, or can support them to come into hospital. And that's quite new, and that's a lovely complement to that telephone service. So it's not just a telephone service, but there is this ability to actually work more closely and go out and see people. And I'm going to hand over to Dave just to say a little bit about some of the work in North Kensington, if there was anything else that you wanted to add, Dave, before other people might want to ask questions.
Just to say that, obviously the conversations that we are having with the community continue. And I think that we're constantly having conversations about issues that the community are raising, which are concerning them. The issue that seems to be coming through in relation to telephone help is not necessarily that people don't feel that they can't phone the SPA, but also that what else can they access? Who can they have a relationship with? Who, when they're feeling stressed and feeling anxious and feeling desperate, who else is around? And how do we kind of create caring kind of communities where people have got access to that kind of level of support, but that runs right the way up to, when people need access to the NHS. So there was something about an earlier kind of intervention that felt that was coming through, and that's a continuing conversation that we're having.
Right. Thank you very much. Yes.
It's okay, and then I'll bring in Janet, who's actually going to be the commissioner in this case. She's got 3 hats probably as well, like the rest of us.
Okay,
I mean, I think there's a comment rightly about the concern of the community about what happens after the 5-year funding.
Sure. Yeah.
I think in terms of the health service and the funding that we have, so we have specific funding for the Grenfell team, but we also have quite significant core funding for our mental health services that comes via our CCG. And I think what Dave and Anne have been doing, and Sarah will be doing in her new role as a borough director, she will be coming into the borough as a borough director, she'll be changing jobs, is actually they are looking at how we're integrating the mainstream services that we already deliver here, learning from our experiences of Grenfell, because we have had incredible experience from our community where we have learned to do things quite differently. Not only in Kensington, but also in other boroughs as well. And some of that learning is, I guess, the legacy of the Grenfell work. So actually, there isn't, I guess, a cliff edge for us as such in terms of the 5 years, because actually what we're doing is integrating the work and looking at some of how we wrap around our services around the neighbourhood, such as in Neo Health, which is obviously the GP kind of PCN, which is in North Kensington. So there's something about the work that's going on now with the community, but with the other partners, that actually means that for us in terms of healthcare, we're not expecting there to be a kind of ending. It's actually something about a phase of the way we transform the services that we've got and the mainstream services that Anne used to run before she changed job locally, so that they are much more in keeping with what the community feel they needed, because they didn't feel they were accessible. They didn't feel that actually a lot of the community got access to the mental health services that were in the borough. So there's something about that's part of the journey that we've been going on with the community.
Yeah,
Jeremy, want to say something?
certainly that's what I experienced as well in North Kensington, through some of these affected by Grenfell, whether they are bereaved families or survivors or neighborhood.
Yes.
So I'm glad that's a transformation you're recognizing there. And what's interesting is the learning of doing things differently, and that's appreciated. Janet, over to you.
So I don't know whether I need to add too much more, actually, because I think
add whatever you like.
I think it is around the partnership, a bit around the planning and the future, and you know, Anne and I, for instance, are continuing to work and building that relationship to make sure that we do have a very good and shared understanding of what is required, and that we aren't making, you know, decisions are made collectively, or discussions are being held to inform or are needed going forward, and making sure we do have that sustainable provision on an ongoing basis, which is part of the work, both you know, within the North Kensington area, but also more widely within our place-based partnership as well. So it's very much translation of that, and also how the North Kensington work we learn from that and build on that for the rest of the borough and our place as well. So I think that would be the only thing that I would add, and thinking through how we get the integration right within health between the CCG and what's traditionally been a provider relationship, and that is definitely evolving and changing as well.
Right. Thank you, Janet. I mean, this is quite a learning time to reflect and build on. Can I call on David? Or would you like Rachel to come in where Janet just finished on her comment regarding partnership? And then I will ask in David. I think
that's where David comes in.
David, your role.
I was just thinking I should have looked right as well.
Yeah, I mean, either. Okay.
To David.
Okay, David, go first. Then Rachel can get ready.
Yeah, thanks very much, Chair. I think what I need to add to what's been said is the fact that we continue to work very closely with our partners, the CCG and also CNWN, to ensure that we kind of influence some of the discussions, some of the changes, some of the plans that's being kind of communicated across the system. And more recently, we've been having conversations with our local communities as well, just to understand, their understanding of the kind of service provisions, their experience base, and kind of, ensure that, we take that on board as we continue the transformation. I think, what is kind of, key is to continue the conversation. And, we've had a lot of support from Councillor Kimani around, chairing some of these community conversations, for us as well. So giving it some, a very good profile and making sure that people feel more comfortable to express their views about, how services can improve. About 3 weeks ago, we had a market store, event at, Portobello Road, market. And that was quite a successful event. We had a lot of community kind of come to us, approach us, some service users, some carers, and some community members and organizations come to the market store and actually kind of provide, gave us feedback around their knowledge of mental health services in the borough, and also how that could be improved across our systems. So that kind of ongoing conversation is quite important as we move forward, because we're doing training later on in the year to develop a mental health strategy, and that work will be done across all partners. So it's not going to be done by one organization, because the provision of mental health services can be cut across a lot of different services and different organizations. So we need to make sure that is very comprehensive and deliver some of the outcomes that people have been saying.
Thank you, David. In fairness, I just want to add for our colleagues and people who are watching us that David Bello is the head of service for mental health in the Royal Borough of Kensington, Chelsea. Thank you very much, and thank you for your effort. I like that. Whose idea that the market store and opening up? Thank you, Councillor Kamali. Well done. Excellent. That's welcome, and this is reaching out. Really appreciate it. So I hope we'll have this more as well in the box. I would like that. So it's like to have innovation. Rachel, can I call on you? Rachel, she's our new director of health partnership in the Royal Borough of Kensington, Chelsea. So it's over to you, Rachel, please. Well, I can't hear you. You are muted.
Sorry, Chair. Can you repeat
Yes,
the question?
clear.
Good evening, everyone. Could you repeat the question?
And just introduce yourself and regarding reflection on the working group and your work, please.
For the, sorry, I'm not aware of that. What can you remind me?
Regarding the partnership.
The place-based partnership.
Yeah.
I think this is the wrong.
Yeah, just comments.
Sorry, which papers? I think
I don't think she's.
No, I'm not presenting. No.
If you can just talk to us about your work, please. Yes, fine. If there is no specific paper regarding the conversation, what do you have?
She's not on.
No, wrong bit.
Sorry, she stood down.
No, I think it's David Bailey we should be speaking to.
Sorry,
Dave.
I think I've got the wrong.
I'm happy to come back to you on anything that you do need.
Yeah. Yeah. Sorry again. Okay, Rachel, that's fine. Thank you so much. If you have any comments, what you've heard, you are welcome to add any comments.
Thank you, Chair.
Okay. Thank you so much. Okay, there's a slight confusion here regarding the information here. Appreciate.
Chair,
so yes,
just to say, I think one thing you do need to do is we just need an indication that you've agreed 2.2 in the report, that the committee is happy to support the
recommendations. Yeah. It's, I mean, we haven't. That's why I thought some people will still add some comments to the paper. That's what I thought it's going to be the case. So we concluded the discussion on this.
Well, I have one.
Councillor Williams.
Yes, one question for all people. I don't know whether
to sum up your paper.
Well, it was a question really.
All right.
All statutory, which is paragraphs 22 and 23.
Yeah.
Dealing with the question of coordination. And what it said was that there's even some bodies the council's involved with and council's not involved. For instance, health partners doesn't have the council. I mean, what is the way forward? I mean, which is the right body to bring everyone together to discuss mental health services and strategy, indeed, let's say physical health as well, specific to North Kensington. It is not the health and wellbeing board, which covers a much, has very wide remit and that covers a much larger area.
I think, David, you want to comment on this one?
Do you want me to jump in, David?
Yes.
Yeah.
Okay, Robert.
Because I think in other boroughs it would be the ICP. In terms of the ICP partnership involves all of the key partners, and that they would certainly in some of the other boroughs they have the kind of subgroups and particular work streams around mental health, and they would coordinate and make sure the key partners are across.
And that is what.
And actually, local authority is absolutely a key partner of that.
Right.
So the place-based partnership, one of our priorities is within that is mental health. We are still evolving exactly how we are working and what we're doing. It's quite focused on some specific issues that we are tackling. But I think again we've even been having those conversations over the last couple of weeks, just about how we ensure that we are discussing the right things in the right way and are prioritising that. So I think there is a work in progress on that. But the forum for that is absolutely within the place-based partnership.
But within that, I think there is in the next few years for something specific for North Kensington with a high degree of voluntary sector involvement. Right?
James, you want to?
Yes, so
yes, come in.
Actually, this week discuss on a Tuesday. So we meet every Tuesday at 8:30. Colleagues will know this, and we had our update on mental health, and we have specifically met to discuss how we link the work of North Kensington, not just from a mental health point of view, but from a wider health point of view into all the strategies, so that you start to see consistency of outcome of everything linked to children, physical health, mental health, and we will start to link that through.
Great, thank you, James. Final comments to you.
I probably wouldn't surprise anyone, but I think a good place for it would be with the local authority. We've hosted already a really good roundtable, a number of them actually now. And David's put together a position paper of where we are as a council. Also, referencing North Kensington more in this report, but mental health was coded within my original papers, and something we're looking at across the borough as well. I think the mental health strategy that we're committed to doing for Kensington and Chelsea is obviously going to incorporate the ICP and CS and the wider NHS bodies. Voluntary sector, of course, GPs, a huge number of people in what is the least case. Well, I think what I'm hoping to do is not to try and lead on this. I think what we're trying to do is actually put our input, but actually be a forum for everybody so that we can have a good conversation, hopefully in person. Although tonight's proven it's still possible to go hybrid. And as a committee, you should be aware that there is mental health strategy coming.
Yeah. Thank you, Councillor Kamali. No, hybrid is good. It's giving opportunities for people who cannot be physically present to have a say and have access. So giving a chance to everyone to be there. And my apology to you, Rachel, bringing you in on this spot. I thought just to come in just for comment.
Not at all, Chair, no problem.
Thank you so much for being with us tonight as well. So here we concluded this working group discussion on mental health with the working group. Again, I thank again Councillor Williams for his patience and thorough work with his team and again the support all he got to reach these recommendation points. So I would like to ask the committee that we can take these recommendations forward and act upon them, and hopefully the future committee will follow up on these and build on in relation for better mental health framework for North Kensington and the borough in general. Thank you, Councillor Williams. Well, you're welcome. Thank you, Robin, and your whole.
Have to formally agree.
Yes, we agree. Oh, I mean that's why I looked at the no objection.
All done.
All done. We formally agreed that. Yeah, thank you.
Can I just say one other thing? That I think this is probably the last time that Robin will be attending our committee, because I believe you are leaving CNWL, and I think on behalf of all councillors, I'd like to thank you for the support you've given your services in this borough, and particularly Grenfell Recovery. I think you were in New Zealand at the time of the fire, but as soon as we got back, you came in, and with other people, particularly some those involved, and Anne, who has also moved on to new higher responsibilities in WLs, and to thank you all for your work you've done for our communities.
Yeah, thank you very much, Robert. And my first meeting was with you in North Kensington, in Nottingdale, discussing the issues surrounding our residents. And thank you so much for all your support you've done for us for all these years. I wish you all the best.
Thank you very much. I'm actually retiring from my crew job, so I'll no longer be a board director, and I'm going to take a couple of months off and go home to New Zealand. But I will come back.
Well,
I have actually agreed that the Grenfell work will stay in my portfolio, albeit I'll be coming back part-time and not as a board director. But I think the continuity is too important.
Thank you. I appreciate it. Yeah. Hopefully we'll see you again. We will welcome you.
I will. Thank you.
Thank you so much, all of you, for coming with us, Janet and David, and Saru, Anne, and David, and Rachel. Thank you for being with us tonight. Appreciate it. So, yes. So now we'll move on to the one item before the last is the minutes of the last meeting. I've taken the minutes that's been read. I've heard some comments regarding correction. Hopefully all members will make their observation on the minute, and then I will sign them off as to a record of our discussion. So any comments on the minutes on the last meeting, please, on the 7th of February? No? No. Okay, thank you very much. So I can sign them off as a true record. Very kind. Thank you. I'll sign them later. Now we move on to the A7. Hopefully that will be a very brief report from the work program. I will call James to introduce the report, please.
Thank you, Chair. Just to say briefly to the committee members, to draw your attention to items 3.6 and 3.5 in the report. For 3.6, this is the last meeting of this municipal year for adult social care and health. On the 21st of March, there will be a meeting of the Family Services Committee, to which you are invited to specifically discuss the report on transitions from children's services to adults for SEND young people.
Yeah.
And on 3.5, like I said, this is the last meeting of this municipal year, but the cycle of meetings will start again post-May. And it's a good time now, I think, to be thinking about long-listing possible items which you may want to take on board or discuss in the municipal year.
Thank you, James.
So, yeah.
So anyway, if you have no confirmation now, I can take any comments, any items by email from the committee members. So please try to contribute there. And this will conclude the item A7. On item A8, any other oral or written items being received? I don't have anything, nothing being received. So I will conclude this Adult Social Care and Health Select Committee meeting, and hopefully the next meeting is scheduled for Monday, the 29th of June, 2022. So whoever going to be after the May election, I will see how things progressing there. May I use this opportunity to thank all of you, Councillor Addenbrook, Williams, Councillor Atkinson, Councillor Woodger, Christine, and our colleague who could not be here with us, Councillor Spalding, and Councillor Round. Councillor Spalding is not feeling well, so I wish him all the best and the speedy recovery. And the long-standing who contributed extremely well to this committee previously, Councillor Freeman, I wish him all the best and a healthy life. And I'm really grateful to everyone who attended this evening, and your support appreciated greatly. And I would not be able to do all the work and the support as we've done it extremely well without the help of James and Yasmin and coordinated with Jackie, who tirelessly tried to put us into the right shape for a good scrutiny. So thank you so much, Jackie, as well, for being with us for late nights. And thank you again for our lead member, who really was very cooperative, very supportive, and we really appreciate all the cooperation you've done with us. You really done very well. So wish you all the best. And thank you very much. Happy, very good. Have a nice, happy life.